Good morning, good afternoon, good evening, esteemed professors, doctors, guests, colleagues, and participants from all over the world. Welcome to Wishbone Day 2026, OI and LMICs, Integrating Recent Advances into Resource-Constrained Care, an international webinar conducted by GPED in collaboration with the Arab Society for Pediatric Endocrinology and Diabetes. Before beginning today's webinar, we would like to inform you of the rundown of this webinar. We will begin with a welcoming address from the Vice President of GPED. This will then be followed by our first presentation entitled Delivering High-Quality OI Care in LMICs, Foundations and Recent Updates by Dr. Mary F. Robinson. The second presentation, Challenges in OI Management in Resource-Limited Settings, will then be delivered by Dr. Rasha Tarif Hamza. Today's webinar will then be concluded with a discussion session led by our esteemed moderator, Dr. Agustini Utari. For the smooth running of today's event, please kindly pay attention to the following rules and regulations. Participants are encouraged to have their videos turned on throughout the webinar. Participants should keep their microphones off unless permitted by the moderators. To obtain a certificate of attendance, participants are required to attend the entire duration of the webinar and fill in the feedback form which we distributed at the end of the event. This webinar also utilizes Zoom closed captions, which would be able to translate the speaker's presentations and talk to your preferred languages. In the Meetings Controls toolbar next to Show Captions, click the up arrow icon. Click the speaking language and then select the language. And on the pop-up, confirm the language you want to set as the spoken language and then click Save. To officially open our webinar, we will now respectfully invite the first speaker to deliver the opening remarks, and she will also be the moderator of this webinar. So it is my great honor today to introduce Dr. Agustini Utari, MD, PhD, who is a pediatric endocrinologist from Diponegoro University, located in Semarang, Indonesia. She graduated as a pediatrician from the Faculty of Medicine, Diponegoro University, and she also holds a master's degree in genetic counseling from Diponegoro University. She did a year of research fellowship on Fragile X syndrome at the Mind Institute in UC Davis, USA, and she also completed her pediatric endocrinology consultancy at the University of Indonesia, Jakarta. She then went on to receive her PhD in Diponegoro University in collaboration with Radboud in the Netherlands. She's an active member of a number of organizations, and she is currently the Vice President of GPED and a member of the IPA Program Area in NCD and Mental Health, as well as the National Newborn Screening of Indonesia. Without further ado, to Dr. Agustini, the time and space is yours.
Thank you very much, Arneta, for the nice introduction. Good morning, good afternoon, good evening, everyone. On behalf of Global Pediatric Endocrinology and Diabetes, or GPED, it is my great pleasure to warmly welcome you to today's webinar with title Osteogenesis Imperfecta in Low-Middle Income Countries, Integrating Recent Advances into Resource-Constrained Care, held in conjunction with Wishbone Day 2026 and in collaboration with Arab Society for Pediatric Endocrinology and Diabetes, or ASPED. I would like to sincerely thank you, distinguished speaker, Dr. Maria F. Robinson and Professor Rasha Tarif Hamza, for sharing their expertise on this important topic. Osteogenesis imperfecta is a complex lifelong condition that requires multidisciplinary care. Although important advances have been made in diagnosis, treatment, and rehabilitation, implementing these advances remains challenging in low and middle income countries. Today's webinar focuses on how recent scientific and clinical development can be adapted to resource-constrained settings to provide practical and effective care for children living with osteogenesis imperfecta. Through today's discussion, we will explore both key principles of OI management and the realities faced in limited resources environment. These perspectives are essential to translating global knowledge into locally feasible solutions and improving care for all patients regardless of geography. At GPED, we remain committed to global collaboration, education, and capacity building. Improving outcome for children with rare or chronic conditions require not only scientific progress, but also equitable access to care, training, and healthcare resources. We are pleased to welcome participants from many regions around the world, reflecting our shared commitment to advancing pediatric endocrine care globally. We also invite you to join our upcoming World Thyroid Day webinar at the end of May and the GPED annual meeting this November. I hope today's session will be informative, practical, and valuable for your clinical practice. Thank you once again for joining us, and I wish you a productive and engaging webinar. And now I will now introduce the first speaker. Our first speaker is Dr. Maria F. Robinson, who will be delivering a talk entitled Delivering High Quality OI Care in Low Middle Income Countries, Foundation and Recent Updates. Dr. Maria F. Robinson is an associate professor at Pediatric at McGill University and a pediatric endocrinologist specializing in metabolic and genetic bone diseases at Sriner Hospital for Children, Canada. Her research focuses on comprehensive phenotypic characterization of skeletal dysplasia and the development of precision health therapeutic strategies to improve biological, psychological, and functional outcome. She investigates the mechanism underlying chronic pain in osteogenesis imperfecta and explore targeted therapeutic approaches. She is involved in outreach initiatives to improve care for children with bone disorder in low and middle income countries. To Dr. Maria F., the time and place is yours.
Thank you so much. I'm really delighted to be here with you today. It's a pleasure. We've been doing this this webinar now every year, and every time I'm just amazed by your questions and your enthusiasm. And I know this is a really important topic for you also. I'm really pleased to be here. So today we're going to really talk about OI, but really coming back to the foundations, we're going to talk about recent updates, but really with a spin of the reality of in resource limited settings. There will be lots of time for discussion at the end after the two talks, so we'll have lots of time to answer your questions. So those are my disclosures. So I do different research trials and clinical trials to find novel therapies for children OI and other rare bone disease. So I work at Shriners Hospital for Children in Canada. So this is what it looks like. So we are a hospital dedicated for children with rare bone disorders. So all we do in the hospital is rare bone disorder, including OI. And we do welcome children from Canada, but also all over the world in different settings to be able to help the care, especially for children with OI and skeletal dysplasias. So today I have four main objectives. First, I want to talk about briefly the diagnosis of OI. I'm going to focus on treatment, but I just want to lay some foundation so we're all talking the same language. I'm going to talk about intravenous bisphosphonates, how to use it, what to be careful of. We're going to talk at the end about the recent advances in OI care. There's a lot of things happening in the field, so I'm going to give you a brief update on that. So this is my first slide that is a little bit more going back to the basic, because I really want to make sure we are all understanding of the definition, because that really influences how we treat and when we think about bone disorders. So I want to make the distinction between what's called a mineralization disorder or rickets and osteoporosis, which OI is a type of osteoporosis, because this question comes up often. So I'm going to show you what the bone looks like when you look at the bone tissue level. So I often do bone biopsy in my patients to look at what their bones look like. So what I do is I take a little fine needle and I take a little piece of bone at the iliac crest. And typically that's what a normal bone look like. So the green here is the mineralized bone, or the bone with calcium and phosphate on it. And the red here is the bone marrow. So usually what you see is you have, so this is the width of the bone, and then you have the cortices on both sides, and in between you have the trabecular bone. So all of this makes a very strong bone, and that's normal. When you have a child with rickets, and that could be any type of rickets, so it could be nutritional rickets, it could be X-linked hypophosphatemic rickets. In those children, you have the same amount of bone, so there's not less bone, but the bone that's there is not well mineralized, and that's shown in pink here. So pink is the bone that was laid out by the osteoblasts, but not yet mineralized, so does not yet have calcium and phosphate on it. And this bone is very soft. So when you look at this bone, there's enough of it, but there's calcium and phosphate missing, which is why you see the red. And so for those children, you need calcium and vitamin D or phosphate, depending on exactly what they're missing. And that's very different from osteoporosis, which is a big umbrella term we use to say that you have bone fragility because you don't have enough bone. And OI is a type of osteoporosis. And when you look at, so this is a child, one of my patients with OI, you see that the cortices are thin. There's holes in the cortices, so it's very brittle. And the trabecular bone, there's not enough trabeculae, and it's very thin. So this bone, you can give as much calcium and phosphate to it, it will not become stronger. The problem is that genetic mutation that does not make good quality bone and not enough bone. And both of that, both rickets and osteoporosis ROI can give low trauma fractures, but they're treated very differently, right? The rickets you'll treat with calcium, phosphate, vitamin D, or burosumab, which is what you give in X-linked hypophosphatemic rickets, and you'll give bisphosphonates to OI. So that's a very important distinction. And when you look at the x-rays of those patients, in a patient with rickets, you'll be able to see right away that there's widening of the growth plate, there's cupping of the metaphysis, there's it looks like a brush-like appearance of the metaphysis. That's very different from OI, where you have very normal growth plate. So you know this patient is not calcium or vitamin D deficient, but you have softer bones, so bowing of the bone, thin bones, and in this case, you have a fracture. So now I'm going to dive really talking about OI and talking about management of OI. So when we think about OI, it has a wide range of severity from mild to severe. So type 1 is typically referred as the mild form. And this could go all the way from so mild that sometimes we diagnose only adults patients when they're coming with their own children because they have such a mild phenotype of fractures and slightly reduced stature. Type 3 is the more severe form that's not lethal. So they will be very, very short, in fact, shorter than even children with achondroplasia. They'll have scoliosis, multiple long bone deformities. They typically will be wheelchair bound. And then the lethal form, that's a type 2. So when we diagnose type 2, the child has to be deceased. So in order to give a label of OI type 2, the child has passed away. That's how we define type 2 versus type 3. So when in a fetus with a severe type, we cannot differentiate which type it will be. It will only be the evolution that will be able to tell us which type it is. And type 4 is between type 1 and type 3, so the moderate form. So they'll have fractures, scoliosis, moderate short stature, and typically will be ambulatory with some type of assistance. So typically a walker, rarely in wheelchairs. And what I really want to drive home, because I often get questions about, can we start therapy if I don't yet have a genetic diagnosis? We don't need genetic diagnosis to be able to diagnose OI. It's a clinical diagnosis. So if you have a patient with fragility fractures, this is a patient with osteoporosis and most likely OI. And there's extraskeletal feature that can help you make this diagnosis, but you do not need genetic testing. If you do have genetic testing, that's great. There's lots of cause now for OI. Most of the time it's caused by mutation collagen type 1, which is COL1A1 or COL1A2. But we have a lot of genes now that are causing OI. Some can be recessive, some can be dominant. Typically, the recessive forms are the most severe. And that's what you'll see most commonly in families of consanguineous between the parents. Those are the extraskeletal manifestations of OI. Very important, though, to say that you could have a child that only has low fragility fracture without those extraskeletal manifestations. But when you do see them, that kind of increases your diagnosis suspicion of OI. And typically, those features are in the context of COL1A1 or COL1A2 mutation. A lot of those other mutations will not give you those extraskeletal features. But classically, they're the blue sclera. We say blue, but it's really gray. Scoliosis, ligamentous hyperlaxity, and dentinogenesis imperfecta, which usually looks like the teeth are fragile, they can chip, and then they are gray. So when the child presents to you, what's the standard approach that you could have when you have a suspicion of OI, which typically comes when a child presents with low trauma long bone fractures? And So usually, and if you have extraskeletal features, again, that will kind of increase your suspicion. But the test that you need to do when you have this child coming is very simple, and you don't need a lot of resources for that. It's the most important single test is that lateral spine X-ray. So you want to take an X-ray looking at the thoracic and lumbar spine from a lateral view, because you want to be able to assess the presence of vertebral fractures. And the reason why this is so important is because vertebral fractures most of the time don't have symptoms. So children do not have back pain. And when you miss the first vertebral fracture, you're at risk of having a vertebral fracture cascade because it changes the axis of the spine. It can lead to respiratory compromise, to pain later on. So very important feature not to miss. And vertebral fracture is like the clinical signature of bone fragility. If you have a vertebral fracture, it's very, very likely to be a form of bone fragility, unless the child was in a car accident or fell from multiple story building. But vertebrae are hard to break. If you have access to a dual X-ray optometry test, that's great, but you do not need that to make a diagnosis of OI. You can make a diagnosis of OI just in the clinical setting of fractures, long bone fractures and vertebral fractures. Blood work is important mainly to rule out a mineralization disorder. So this is to rule out rickets. So you want to draw calcium, phosphorus, vitamin D if you can, magnesium. And we look at creatinine. This is just to ensure there is no renal problem, because bisphosphonates, which I'll talk about, are excreted renally, and therefore you want to make sure you have normal creatinine before you give bisphosphonates. Another important test is an X-ray of the growth plate to make sure you're ruling out rickets. And then obviously genetic testing if it's available, but again, not needed. And the last thing you want to think about is make sure you're not missing a secondary cause of OI, a secondary cause of osteoporosis. So that would be a child, let's say, with chronic disease like leukemia, like a child on steroids, or a child with celiac disease that could have another reason to cause a bone fragility. You want to exclude that before you make a diagnosis of OI. I've talked about X-ray of the lateral spine as the single one most important test. This is just an example of it. So this is a lateral spine X-ray on a child with no vertebral fractures. So you see the vertebrae are nice and square. When you have vertebral fracture, what happens is you lose height in that vertebral body, and that's what we call compression. So the gravity is kind of, the bone is not resisting the gravity, and that's why it's collapsing. Whenever you have a loss of more than 20% of the height of your vertebrae, that's a vertebral fracture. And you can grade them in mild, moderate, or severe. But what really is important is to being able to say if there is a fracture or not. And that's really that 20% difference. And that's the grading system is called the GPED grading system when you look at mild, moderate, or severe. And that's a spine X-ray of a child with OI with multiple vertebral fracture. So you see here the vertebrae are collapsed. Those are severe biconcave fracture. So that's a child that would absolutely need bisphosphonates. This is a word on DEXA that I've touched on. So the DEXA, the one word I want to say is, again, if you don't have a DEXA to diagnose, that's okay, because we don't use BMD alone or even to diagnose OI. We really use those clinical features. But DEXA is really important when you put a child on bisphosphonates and you want to make sure you're not overshooting and having too high of a DEXA. But the one piece I want to make about DEXA is a two-dimensional tool. So it's basically giving you a shadow of your bones. So it's looking at bone density, but it's not really a density because it's two-dimensional. So if you have, for example, the bone on the left and you're comparing to the bone on the right, they both have the same density when you look at it. But the DEXA would interpret the same way it would interpret a shadow of it. So for the left one, it's going to see this one as a lower density just because it's smaller. So meaning that the DEXA will not be able to recognize that a bone has the same density when it's smaller. So that means that for kids, they will always have a lower Z-score on DEXA. And when you have a DEXA result on your paper, typically it will give you what's called a Z-score, which is looking at your density compared to another child of the same age, the same sex, the same ethnicity. That's called a Z-score. And what's important is when you look at that Z-score, you want to compare this to the height Z-score. Because if your child is shorter, your BMD will automatically be shorter, and that's not a problem. So for example, if your height Z-score is 5 standard deviation below the mean, you will expect your density to be around the same thing, 5 deviation below the mean. So what you look at is you want to make sure they're somewhat similar to the height Z-score. So that's important to not overcalling a low BMD. Here I have this one, a question that came up before the webinar is how can general practitioner do to diagnose OI, right? When you have those kind of less access to less resources. So the 3 most important thing is recognizing fractures that are occurring without significant trauma and seeing that this is never normal. And when sometimes it's hard in clinic when you're like, is this enough trauma or not? The rule is that if you have a child that breaks a long bone, and they are doing that at no more than a walking speed or no more than standing height, that's never normal. So a child that's fracturing a long bone when he's walking, not normal. A child falling from their own height, fracturing, it's not normal. If a child is running and breaking a tibia, that can be normal, or if a child's falling from more than their own height. This is important, but also important is to know which bone fractured, because if you have a very major bone, like a humerus or femur, this is to me an extra red flag because it's quite hard to break a femur or humerus. So when I see that the patient has either femur or humerus fracture, I'm more suspicious and I will be more aggressive in starting therapy than if I hear about a radius, because radius is quite easy to break, and especially in active kids. The second item for the general practitioner is that vertebral fractures, important not to miss them, important to look at that spine x-ray. And the third one is make sure that you're not missing something that's easy to treat like rickets. So that's why you want to have your blood work. And if blood work is not possible, at least have an x-ray to look at the growth plate to see if rickets is present. So before we dive into the treatment, this is a little summary of what we talked about. So OI is a clinical diagnosis. You can make a diagnosis without genetic testing, and it's classified based on phenotype, so mild, moderate, or severe. It's not classified based on the genetic mutations. Who to treat? So I kind of alluded to that. So you want to treat a child with suspected OI that has at least one vertebral fracture or at least one significant low trauma long bone fracture. So you just need one femur fracture and you need to start therapy, or one humerus fracture. If you have a bone that's less significant, like for example, a radius, you may want to wait for 2 radius of the long bone. Do fracture of the radius before you start therapy. So you may be a little bit less aggressive. The second reason to treat OI, even if they don't meet those criteria, is if they have pain, because pain is a real problem in OI, and bisphosphonates are extremely potent for bone pain. So you do want to start bisphosphonates if they have pain. So next question is, how do we treat? Once we've made the decision to treat, how do we actually do that? As Dr. Utari was mentioning in the introduction, it's a multidisciplinary treatment. One single treatment will not be that helpful in isolation. So one aspect is the medical aspect, that's the bisphosphonates, which I'll focus on. The orthopedic surgery is very important, because if you have a significant bowing, like in this child with OI type 3, you have significant bowing of the tibia. No matter how much bisphosphonates you give to that bone, the bone will continue to break, because this apex at this the junction between the bowing will always break, even if the bone is strong. You need to make that bone straight before you can actually stop fracturing. Another example in OI is the severe scoliosis we have. Those children often need spinal surgery to correct the scoliosis. And the third thing is the rehabilitation piece. And for those of you that were there last week when Corinne Mercier gave her great talk about rehabilitation, so she's our physiotherapist at Shriners, the importance of rehabilitation after fracture, but also to make sure that we maintain strength, because bone and muscles talk together, and you need strong muscle to have strong bones. So diving into bisphosphonates, so this is a little cartoon of how bisphosphonates work. So in this upper field, this is a normal bone without bisphosphonates. So you have those huge cells that they're multinucleated osteoclasts that resorb the bone here that's shown in green, which is the mineralized bone. And the osteoblasts, they are laying down osteoid, which is the unmineralized bone, which will then become green here when you have calcium and phosphate on them. So in a normal setting, the osteoclast will resorb some bone and the osteoblasts will lay down bone, and you'll have this kind of balance between both. When you give bisphosphonate, which is in this lower panel here, you intoxicate the osteoclast. You make them no longer able to resorb bone. But the osteoblasts will still continue to lay down new bone. So you have this net effect of having a thicker, here is a cortical bone, so in this sense, you'll have a thicker cortex. Now the problem, and I'll talk about later, is so bisphosphonates will stop bone resorption, but they will never make your bones bigger. They will never make the circumference of your bone larger. And that's why kids continue to fracture with OI, even with bisphosphonates, but they will make it denser. And the other thing to mention is that they stay in the bone for years, which is why we love them so much, because OI is a genetic condition. So you do want to have a therapy that stays on for 20 years. That's what we want to protect them long term. So if you have a child that comes to you and you want to start bisphosphonates, what do you need to do before you start? So those are the safety measures. So there's two things, safety measure you always have to do. One is you want to make sure your patient's not deficient in calcium and vitamin D. Because if you give bisphosphonates to a child that has vitamin D deficiency or has calcium deficiency, you could cause significant harm, because bisphosphonates will lock in the calcium in the bone. So if you don't have enough calcium, you can have severe hypocalcemia that could be life-threatening. So very important to always look at vitamin D and calcium and to correct deficiency before you infuse. So you want to make sure they're at least above 30 nanomole per liter before you treat. And you want to make sure calcium is normal and they have appropriate calcium in their diet. If they don't, you want to add a supplement of calcium to make sure they have enough calcium. And typically on the day of the infusion, the 5 days after the infusion, I usually put them on a calcium supplement just in case, because they need so much extra calcium when you give the drug, and you want to prevent hypocalcemia as much as possible. The second thing you need to do when you start bisphosphonates is you want to make sure you have normal renal function, because you can cause renal damage if you have poor renal function. That's super, super rare, but you want to make sure you have normal serum creatinine. And if you don't, you can still give it. You just need to adjust your dose and give it over longer. And usually you would prioritize pamidronate when you have abnormal renal function rather than zolindronate, because it's less toxic to the kidneys. That's a question I get often. The bottom line is you want to give intravenous and not oral bisphosphonates, and that's very clear, because oral bisphosphonates will not protect the spine. You cannot prevent vertebral fracture with oral bisphosphonates. They're not bioavailable enough. They're about 1% bioavailability compared to the intravenous bisphosphonates. So there's no role for oral bisphosphonates in pediatrics. So what do bisphosphonates do? They do lots of things. They increase bone density in a very, very potent way. I've never had a single child on bisphosphonates not go up on their density. And that is why we need to make sure it doesn't go too high. And I'll show you how to do this, because you can go too high with bisphosphonates. They reduce long bone fractures by 50% about. So you will not completely reduce the rate of long bone. You will only reduce them by 50%. And remember, if your bone is bowed significantly, bisphosphonates won't do anything to that. You need surgery to strengthen that bone. Bisphosphonates are very good at reshaping previously compressed vertebral body. So when you have those vertebral fractures, if you give bisphosphonates to a child that's growing, because if they're not growing, bisphosphonates will not do anything on reshaping. But if you do it when they're growing, you will most of the time have what we call reshaping of this vertebral body. So you see here completely normal vertebral bodies come and they were completely collapsed before. And that's what a child with OI type 4 treated with bisphosphonates. They're very good for pain. When we use them for pain, often what works is smaller, more frequent doses. So often I'll give a smaller dose, but every 3 months, to really get the pain into control. And they also increase grip strength or gross motor function. Should I use alendronate or pamidronate? That's another question that comes up. It does not matter. They're both excellent. They're both reducing fractures. So alendronate is more potent, so will have a larger impact on your density, but pamidronate is still a very good choice. The main difference is the cycle interval. So alendronate you'll be able to give less often, so every 6 months compared to every 4 months for pamidronate. And the other thing is pamidronate, when you infuse it, it's about 45 to 50 minutes. Pamidronate, if you give the full dose, you'll need 3 days. And during the actual infusion, it's about 3 to 4 hours. So it's longer, more nursing time. So it may be more cost effective to use alendronate, although alendronate itself is a little bit more expensive. If you have the choice, I typically prefer alendronate just because it's more potent and you give it less often. But again, pamidronate is still a very good drug. This is an important slide about the doses. So typically for alendronate, we want to give it every 3 months for infants and then every 6 months later on. And all this kind of fancy adjustment, the reason why we do this, where we adjust the dose based on DEXA, is to make sure we don't overtreat. So that's why it's important to have a DEXA once you're on bisphosphonate. But I'll show you other ways if you don't have access to a DEXA to still give bisphosphonate safely. This slide is kind of the same thing, but put in a diagram. So when you have a child that you decide to start bisphosphonates because they have moderate or severe bone fragility, right? So they fractured an important long bone. Typically, the first ever dose, you always want to give 1/4 of the dose. So in this case, 0.0125 milligram per kilogram. And this is because this was shown to reduce the hypocalcemia and the severe side effects. That's only for the first dose. Once you've done that, then you want to give a full dose of alendronate if your bone mineral density is less than -2. If it's more than -2, so in the normal range, you want to cut your dose in half. And if it's above 0, you want to cut your dose in half and only give it every 12 months. So all of this is really just to prevent overtreatment, which is really the thing we're scared about when we start therapy. It's overtreating. So it's all about ensuring you're not overtreating. Most of my patients, just to give you a sense, when they're on a maintenance doses, typically it's about half the dose. Not a lot of patients will need your full dose. That's another kind of protective way to make sure you don't overdose. And then as long as they're still growing, you continue with your DEXA every 6 months or every 12 months, and then you continue to adjust. And once they're done growing, that's when you can stop the therapy. I've had one question coming from the group about asking, what do I do if my BMI-Z score is above 2? So it happened to me a few times, although if you follow this, honestly, it's quite rare. I could count them on my finger out of 100, like over hundreds of patients that they're above 2. So if you follow this, they're really going to do that. But if they are above 2, I would lower the dose significantly to 0.0125 every 12 months. And if you're really like still high, you could take a pause because you really want to make sure you're not overshooting. So you could pause your therapy and continue with DEXA. And once it's back to a normal range, you could restart your DEXA. This is the schedule for pamidronate. So pamidronate, again, more frequent. In your infants, you want to give it every 2 months, then every 3 months for the 2 to 3 years old. And when they're above 3 years old, it's every 4 months. There's something called the short pamidronate schedule, which is half the dose. Most of my patients are on pamidronate. They only need half the dose. And the nice thing about this is, as long as you're not over your 60 milligram in a single dose, you can give that in 1 day. You don't need your 3-day like we used to do before, as long as you're less than 60. And the reason for that is over 60 is not good for the kidneys. You always want to protect your kidneys by this max dose. So that is totally an appropriate thing. And remember, when you first ever dose, you always want to make sure it's 1/4 of a dose to minimize your side effects. This is a case I want to show you to drive the point home about when to start and the importance of starting bisphosphonate. So this is a little patient that came to a clinic outside of my clinic when she was 5 months of age. She was pulling to stent and had a femur fracture. So you see here her femur has a diaphysis fracture. when we did her DEXA score, she had a DEXA score of -5 and she had a normal height. So that's considered low because it's not close to her height Z score. And she has a variant in a gene called IFITM5, which is a gene causing OI type 5. That's not really relevant though. Like you could still just look at this fracture. You know, this is not normal for an infant that's not having a significant injury to have femur fracture. This is her spine X-ray at 5 months old, so completely normal spine. And at that time, she should have been treated on bisphosphonates, which was not the case. And when I saw her for this first time at 15 months, you see how her spine is completely collapsed now. She has numerous vertebral fractures. And that's what we want to avoid. That's why the minute you have that low trauma fracture with significant bone, you want to start therapy as soon as you can. And you would prevent damage like this child that came in significant pain by the time I saw her. So should we start bisphosphonate in infant with suspected OI? Yes, as soon as possible and as soon as renal function is established. And that can be as soon as 5 days of age or even 3 days of age if renal function is established. I want to say one word about how do you manage OI type 3. So remember, we can only say it's OI type 3 once the child has unfortunately passed away. But before they pass away, you can still manage them aggressively to give them good quality of life at that point. This is a patient that I had seen in utero that had significant bone fragility, obviously in utero, because her bones were very heterogeneous, they were coarse, she had numerous fractures. But when we saw that in utero, we didn't know if she would be a very severe OI type 3 or if she would be an OI type 2. And regardless, you want to provide the best care for those infants. So this is a chest radiograph at 9 days of age. So you see very small rib cage, lots of callus, right? So we call that kind of beads, ribbon on a beads. So there's kind of like beads here, which is the fractures. And often those children die of respiratory compromise because of lung hypoplasia, because when they were in utero, the chest was so small because the bones were so brittle that the lung did not develop. She has numerous vertebral compression fractures, even though she never saw gravity, right, when she was in utero. Skull X-ray shows severe thinning of the skull, severe plagiocephaly. This is her left arm, so very gracile, heterogeneous fractures. And here is her lower extremity, so again, very, very heterogeneous bone. I treated her with bisphosphonates as soon as I could, which for her was 7 days of age. And the reason why this is so important is you want to do that for pain. Those infants are in significant pain and they need morphine if necessary, pain control, and bisphosphonates ASAP. And she passed away at 16 days of life on CPAP, but still was mostly pain-free with this treatment, which is why it's so important to still treat them with bisphosphonates. So treat the pain, gentle handling, and casting is really if you absolutely need and you want to be very, very light so that you don't create further fracture by having a strong rigid cast. How do we treat severe OI perinatally? So when you have that, ultrasound showing suspected OI prenatally, you want to involve your team as much as you can, as much as is available, mostly the maternal fetal medicine folks. There's no evidence that vaginal delivery is better or C-section is better. And you want to avoid instrumentations though, because you can especially create significant caput with instrumentation and cause quite a bit of harm, including brain bleed. Postnatally, as I mentioned, you want to do aggressive pain control, rest support, especially for the first 2 weeks, because this is when calluses are forming from the fractures of the birth. So this is really when they're in most significant pain. You can breastfeed, but often those children have significant respiratory compromise and they can have a weak sucking reflex. You want to supplement vitamin D if you're thinking they may be deficient. You want to start intravenous bisphosphonates as soon as renal function is established. That's one important point that I often make is that if your baby's intubated, you can typically favor zoledronate because it's more potent. But if your baby's not intubated, usually I favor pamidronate because pamidronate is more gentle and there's less chances of exacerbating respiratory compromise with pamidronate, because often if you have severe OI and the baby's not intubated, when you give the bisphosphonate, that will worsen the respiratory status. So that's why you want to favor pamidronate if their airway is not protected already. You want to have a safe handling site at bedside, respiratory support, And very important to cluster care. So you want to ask your team to do all care at the same time because you want to allow uninterrupted healing of the fractures. This is tips about how to handle infants with severe OI. The OIF has a free booklet that's very, very good that talks about how the parents should handle their infants with OI, how the nurses should do. So that's all available online on the oif.org website. So very, very good. And it gives little tips on how to prevent, because that's a very kind of common question whenever you have this infant with type 3 OI that needs care on how to handle them. Okay, how long should bisphosphonates be given? That's a very easy question. It's until they're done growing. And you never, unless you have a very high DEXA, like I mentioned before, want to stop before end of growth. And there is a very clear reason for this. And that's because I'll give you this case as an example. So this is a 5-year-old with OI type 4, it's a boy. And he was treated with pamidronate until he was 3 years of age. And you see the bone that was treated with pamidronate is very dense. And then you have this interface at the interface between the old treated strong bone and the new treated weak bone, right? Because the bone continues to grow and the area that is not treated is very weak. If you stop treatment when they're still growing, you have those fractures at the interface between the strong bone and the weak bone. And that's what we're trying to avoid. That's why you never want to stop therapy in a growing kid. When they're done growing, you don't have this issue anymore because all bones have been treated. So that's when you know you can stop. So that's why we don't favor drug holidays and we never stop during growth. How do you follow children with OI? When they're on treatment, usually I say to try to see them every cycle and make sure they have normal iron, calcium, and vitamin D. You don't need to take your vitamin D level every time, but make sure that they're not deficient. And then you want to have your spine radiograph annually to make sure that you don't have new vertebral fractures. And DEXA is really to ensure you're not overdosing. If your children with OI, you're following in clinic, they have mild OI, they're not on therapy, the single most important test you want to do every year is a spine X-ray. Because if you do find a vertebral fracture, then you would start therapy. So what can you do if you don't have access to a DEXA? So there are ways to look at overtreatment, right? Because this is really what we're trying to do when you're treating with bisphosphonates. You could look at your radiograph and see if there's any signs of overtreatment. So usually signs of overtreatment would be kind of those areas of sclerosis, and you could have a fracture at the zone of sclerosis. The other thing we can see is this Erlenmeyer-Flass deformity. So this is a normal femur modeling, or the shape of the femur here. And when you start to no longer have this nice outward shape like this, that's, this is severe overtreatment. And the other thing you could see is sclerosis at the metaphysis. That's another sign of overtreatment. The other thing you could do is, out of a hand X-ray, you could estimate BMD out of your hand X-ray, and there are techniques to do that. It's called DXR, and now with AI, this is even available with softwares. And then, of course, you want to make sure you never overdose, and you favor half dose if you don't have access to a DEXA to make sure you're not overtreating. This is just showing, again, when you follow those children, in addition to DEXA, you obviously want to follow their growth. There are growth charts now available that are freely open access. When you look at the supplements of that paper, you can have all the growth charts. And you could plot now the children we have for boys, girls, for each type of OIs. And that way you can assess height and you can assess weight for those children. Goals of bisphosphonate treatment is really to improve functional outcomes, right? It's all about functional outcomes. So we're treating because we want to reduce long bone fracture, we want to make sure there's no pain, and we want to make sure we prevent further vertebral collapse and new vertebral fractures. We're at the last few slides here. So what are the side effects of bisphosphonates? Acute phase reaction is the most common. So about 12 to 72 hours after giving you bisphosphonate, children have like the flu, right? They have fever, pain, they can have vomiting, nausea, headaches, looks like they have the flu, and that usually goes away after 72 hours. And the first dose is usually when we see that. The second dose, they have it a little bit sometimes, and the third dose, they don't have any more symptoms. And you can medicate those acute phase reaction by giving calcium and giving a densitron, a gravel, and Advil or Tylenol. Those are other side effects you can see with hypocalcemia, and those are really more rare, the other ones that we really rarely see. So the one I advise my patient is really the acute phase reaction, the hypocalcemia. So just for the sake of time, I just want to talk about this one here, the current gaps in OI care. So what are we not doing right now in OI, despite everything that I've showed you? There's two things. One is pain. So kids and adults with OI, majority have pain. We've done survey of that showing this. And treating pain is tricky. It's multi-dimensional. Bisphosphonates is good for pain, so that's for sure, but it's not sufficient. Physio and occupational therapy is a must. There are new therapies that we're testing out, surgical intervention and psychological intervention, because we know there is a big relation between fear of fracture, the anxiety in OI, and the pain itself. So if you have access to social work, psychology, this is really important for kids with OI. This is just one study looking at mindful self-compassion, which is a psychological treatment. And with this, in OI, when we give this, we're able to decrease pain and pain interference. So very, very closely related, because the areas of the brain are not the same in those children and adults because of chronic pain. So psychological intervention can change those areas. The second gap that's remaining in OI that we're not targeting is the size of the bone. So remember I said the bisphosphonates are very good at increasing the density, but they don't change the periosteal circumference of the bone. The bone is still small. So this is an example of a PQCT when we look at the cross section of the bone. This is a control, this is the radius, and this is a bone with OI treated with bisphosphonates. So you see it's super thick, but it's still small. And that's why it's an issue, is because the bone are still small and they can still break. And the pharma companies are hard at work right now to create the drugs that will increase the size of the bone, but so far the outcomes are not great, unfortunately. So I'll just show one example is the anti-sclerostin antibody. So that's a drug targeting sclerostin, because sclerostin inhibits bone formation. And there was one large trial, phase 3 trial in children with OI done by Ultragenyx. That's an intravenous treatment. And a few weeks ago, the data came out and the drug did not work at reducing fractures. So that was super unfortunate for the community. There's another agent that's also an anti-sclerostin antibody that's called romosozumab. This is still in phase 3 trial. We'll see what the data is. The hope is that we could increase the size of the bone by forming more bone, and that could potentially help with fractures, but the jury is still out. So nothing for anyone else to do than just waiting on those data. There's another drug called TGF-beta that inhibits bone. So when you make an antibody towards TGF-beta, you can increase bone formation. And there are trials right now in adults with OI looking at this. So again, super early, but potentially promising for the future in OI. So we call those anabolic therapy, and really in my head, those pros and cons is that if they work, they could increase the size of the bone, so we could use them with the bisphosphonates to have larger bone. But the problem is the minute you stop those antibody, the bone will go back to where it was before, because it doesn't stay in the bones for a long time. So we will still need bisphosphonates to seal in the effect of those treatments. So bisphosphonates are here to stay. No other drugs so far are better than bisphosphonates. So that's my last slide. I was asked just kind of demystify common myths in OI. So I've listed here things that I hear sometimes that are not true. So the following causes OI. So lack of calcium and vitamin D does not cause OI. Advanced maternal age does not cause OI. Advanced paternal age, there may be a small association, but not the same as what we see, let's say, with achondroplasia. All patients with OI have blue sclerae. This is not true. You can have a patient with completely normal sclerae and teeth and still have OI. Children with OI need a drug holiday. That's not true. They don't need a drug holiday. Actually, that could harm them. And the bisphosphonates are linked to atypical femur fracture in OI. That is also not correct. This is only something observed in osteoporosis women later on. So this is a little summary of what I talked about. So I talked about the fact that there's a difference between mineralization disorder and osteoporosis, and we treat them very differently. Only osteoporosis and OI should be treated with bisphosphonates. Children with vertebral fracture or more than one major low trauma long bone fracture should be treated with intravenous bisphosphonates. You always want to make sure you have normal calcium and vitamin D and normal renal function before you start. Bisphosphonates should be started as soon as bone fragility is identified. You don't want to wait. You want to treat until the end of growth. I didn't discuss that, but you do want to hold bisphosphonates 4 months after osteotomy or spinal fusion to prevent non-union, but you don't need to stop after fracture. And no other drugs are available for now, but there may be some promises on other therapies that we're still awaiting. This is my email address. I'm happy to take questions later on as well. I think feel free to reach out. And the OIF has also excellent resources. Thank you very much.
Thank you very much, Dr. Maria, for such an insightful and excellent presentation. I'm certain that our participants have a lot of questions, and please put in the Q&A chat room. And now it's my great pleasure to introduce our second speaker, Professor Rasha Hamza. Professor Hamza is the head of the Pediatric Endocrinology and Obesity Unit at Ain Shams University and currently serves as a chair of the SP Leadership Academy. She previously chaired the SP Education and Training Committee and has played a key role in pediatric endocrine education, organizing the first SP Winter School in Africa and hosting the ASPED SP Endocrine Academy in Cairo. She is also Vice President of Arab Society for Pediatric Endocrinology and Diabetes, serves on several editorial boards, and is an internationally recognized speaker and researcher with a special interest in obesity and bone disorder in pediatric endocrinology. To Dr. Rasha, the time and place is yours.
Thank you very much, Agustini, for the very kind introduction and for inviting me to join this wonderful gathering. Hello, everybody. Good morning, good afternoon, and good evening. Can I share? Yes.
Yeah.
Yeah, I think it's working now. Yes. So can you see my slides? Yeah.
Yeah.
Yeah, so it's a real pleasure to be with you today. And thanks to Mary Eve for paving the way for me. She made my job much easier. So I'm going to build on what was previously said. And the focus of my presentation is challenges that we face in diagnosing and managing OI in resource limited settings like my country. And to start, let me tell you that Egypt is one of the most populous Arab countries, huge population. More than 110 millions. We have 27 governorates. It's ranked 15th in the world as a population. And as you all know, it is a North African country. And in fact, we have higher incidence of recessive conditions because we have a high consanguinity rate. And you can see in this report that the overall consanguinity is more than 20%. So even the rare conditions, we can see a good amount of them. And taking a closer look at the main healthcare providers in my country, Egypt, the base of the pyramid is the Ministry of Health. And then we have health insurance organization. We have universities and research institution, and then the military and police hospitals. And finally, the least is the private sectors. And then you can see on the right side the funding sources for each entity. So this is to give you a very quick idea on how our health pyramid goes. This is where I work. This is Ain Shams University. It's a quite old university hospital. It was founded in 1931, funded by Ministry of Health and Education and some charities. It is composed of 4 major hospitals. We have 3 secondary and tertiary care services to all populations. And in addition, our staff have their own private clinics outside university. And this is how our old university looks like. Now, going closer into the Pediatric Endocrinology and Obesity Clinic, Ain Shams University, where I'm honored to lead this. It was established in 1980. It's a twice-weekly clinic. We see 30 patients per clinic, and if we open the number, we can see more than 100 patients. We have a multidisciplinary team, 2 pediatric endocrinologists, 2 to 3 pediatric endocrine trainees. We have a psychologist, a dietitian, and we have access to other subspecialties if needed. And the source of referral in our Egyptian government rates. And we are now working on establishing a metabolic bone disease clinic, which falls under the umbrella of our pediatric endocrinology clinic. And this is the checklist that we use at Ain Shams University Hospital for OI. We just tick the boxes when we face a case of OI patient. Of course, speaking about the OI challenges, we can say a lot. And we heard from Mary Eve, we have a lot of challenges that could be applicable all over the world. The fractures, the deformities, the psychological impact, a lot to say. So we have a lot of health-related challenges. But speaking about challenges in resource-limited settings like the country where I live, this is the part that I need to focus upon. Are there additional challenges in resource-limited settings? Now, let's see. And these are snapshots from challenges that we face through real-life case scenarios of some Egyptian children with OI that I'm going to share with you throughout my presentation. The first, and I think a very important challenge, is the late diagnosis, because sometimes children are not even diagnosed as having OI. They are misdiagnosed as having any other metabolic bone disease or rickets or whatsoever. Now, let me take you to the story of Layla. And Layla is an 11-and-a-half-year-old girl with fractures twice. She only had 2 fractures in her life, and that's why she wasn't really diagnosed as OI from the beginning. So there was a late referral of this girl from Luxor. She had mild short stature. Again, some people feel that they should be very short to diagnose OI. She has blue sclera. As you see in the X-ray, she has thin cortices, overtubulation of the tibia, fibula, healing fracture, as you see here in the tibia. And you can easily recognize bowing of her radius, healed ulnar fracture, and the DEXA scan showed not so severe osteopenia, a total Z score of -2.2 SDS, lumbar Z score -2.1, and the neck femur Z score -2.3. And this is the reason that the girl was not diagnosed from the beginning. It's not a straightforward, it's not a severe case of OI. And this goes with type 1 OI. And let me tell you that osteogenesis imperfecta is an ancient disease. And I would welcome you all and gladly invite you to join our marvelous Grand Egyptian Museum in Cairo. And here you can see a child mummy with OI dating long time ago. You can see the photos of this kid. And this is the earliest OI case which was partially mummified Egyptian infant skeleton dating 11,000 before century. So I would like to advise you to come to Cairo and visit us and see the Grand Museum and this child with OI in the museum as well. So I think that you agree that when managing children with OI, every step counts, because you are not just leading the child, you're leading the whole family and maybe an important part of the community. And the critical question here when facing such a case is it a coincidence or a disease? So when to consider a child with fractures for assessment? First of all, if you have vertebral fracture, this is very important, as Mary Eve said, or long bone fracture. So if you have vertebral fracture, even if once, assess the bone health. And if you have 2 or more long bone fractures by the age of 10, or 3 or more long bone fractures by the age of 19, or bone mineral density, SDS or Z score less than -2 standard deviation for age, sex, and height, again, you have to assess the bone health. The other way round, if you have less than 2 long bone fractures before the age of 10 or less than 3 by the age of 19, just advise sufficient calcium intake, serum vitamin D being above 50 nanomoles per liter, and encourage weight-bearing activities. So this is the first question that we need to answer. Is it important or not? Is the fracture significant or not? Another thing is red flags to exclude child abuse, because some pediatricians couldn't really differentiate between OI and child abuse. Sometimes they misdiagnose it, or it leads to late diagnosis. Of course, evidence of neglect, like malnutrition in the child, untreated infection, bites, discrepancy between history and fracture severity or mechanism, suspicious skin injuries like bites, burns, bruises, look behind the ears, mouth, genitalia, and there are specific sites highly suspicious for child abuse, like bucket handle fractures, corner fractures, ribs, acromion, spinous process, sternum, or occipital fractures. Plus age below the age of 6 months. I'm not saying that in all cases it will be child abuse, but just put it in mind and exclude it when you face a child with multiple fractures before jumping to OI. We all know this very old silence classification, classifying the classical 4 types of OI due to mutation in COL1A. We all know these. And let me take you to the story of these 2 brothers referred to me from orthopedic surgeon. Ziad is a 7-year-old child with 3 fractures in the last year. His brother Omar, 2.5-year-old with a single fracture. Their dad had 2 fractures over the last 3 years. Both are short, but the elder is much shorter compared to the younger. They have normal hearing, normal to gray sclera, it's not very blue, and the teeth is normal in both of them. You can see here, these are the x-rays of the elder brother, very thin, and this is the typical codfish vertebrae, protrusion acetabuli, and the DEXA scan came low. So these are type 4A OI. And the challenges here in such a family, of course, they had multiple surgeries, especially the elder, the cost of treatment, they could not afford paying for surgery or buying the bisphosphonate, and some family problems. The mom started accusing the dad of being the cause of the trouble of her kids and the whole family, and the end was family disruption and a lot of social challenges. So, of course, we all agree, we can't agree more on the psychological impact on the patients and their families. So I think that OI is a community problem. It's not just the child. There could be some social, psychological, family problems with a lot of impact on the families. And let me take you to the story of Fatma. Fatma is a 10-year-old who experienced fractures 5 times in 2 years. Of course, this is significant. At first, unfortunately, the orthopedic surgeon misdiagnosed her as rickets. And by the way, this is very common, not only the late diagnosis, the misdiagnosis. You can see here clearly the girl had bowing, and this is what made him go for rickets. She has recurrent bone pains, and this is one of the most significant symptoms in patients with OI, which deserves a lot of attention. The girl was very short, her height SDS minus 2.8. She has decreased hearing, and her sclera was normal. She doesn't have blue sclera. She also has Osteogenesis Imperfecta. You can clearly see in the X-ray osteopenia, thinning of her cortices, and the typical codfish vertebrae, compressed, very thin, very osteopenic. And of course, the DEXA scan Z scores came very low. This is type 4B OI. And again, other social and psychological problem. The girl refuses to go to school, even with a shadow teacher. She couldn't cope. She is psychologically upset. And when I asked Fatma to draw what she felt, she drew herself socially withdrawn, crying, sitting alone, and other kids are playing and enjoying their time in the sun. We couldn't agree more on the heavy psychological burden in those children and their family. And another challenge is referral to tertiary health care centers. In Cairo, it's easy to find some tertiary care centers, but going deeper into other low economic governed rates like Luxor, Aswan, Delta, and other areas, it's not always easy to find a very well-equipped tertiary care center. And even in Cairo, it's not in every hospital. It's just in the big universities where you can find a well-equipped tertiary care center for those patients. Another story where we go to is Malika, is a 4-year-old girl who came with recurrent fractures since birth. And when I asked her mother, how many times did he experience fractures? She said she couldn't count it. It is uncountable. The girl has severe deformities, short stature. She's very short. She has severe bone pains. She's crying all the time because of the bone pains. Her hearing is normal, and she has blue sclera. Again, Osteogenesis Imperfecta, severe osteopenia, thinning of the ribs, and look at the vertebrae, markedly osteopenic, and the typical codfish vertebrae. And you can clearly see here the flared metaphysis and the popcorn appearance, typical of type 3. And here, this is a fracture with extensive callus formation. And of course, as expected, the DEXA scan came very low Z scores. This is the typical type 3 OI. Unfortunately, orthopedic surgeon literally told the parents, there is no treatment, just take her, go home, there's nothing to be offered for this child. And unfortunately, they took the advice until they discovered that there is a treatment and there is a pediatric endocrinologist who can help or give bisphenate or so and so. So she stayed for some time following the advice of orthopedic surgeon that there is no treatment, just let her stay at home and take care of the fractures. So following the 4 types, then appeared another 4 types until type 8 OI. So it was 5, 6, 7, and 8. And we started to hear about autosomal recessive types of OI. And then the list grew longer and longer until we have more than 20 types of OI, the latest published in 2020. And there are variable genetic mutations and phenotypes. You can see the classical 4 types, COL mutations, And you can see the other list of variable genetic mutations. And I think with the advance of genetics, the list is growing more and more. And I think that the future holds more. And you can see in this table the OI mouse models and their genetic characteristics showing future findings. And if you need to check more of the genetic mutations, you can have a look at this paper published in European Journal of Endocrinology 2020. So based on the recent genetic findings, OI functional classification is classified into 5 main groups, either due to collagen structure or function, collagen modification defects, collagen folding or cross-linking defects, mineralization or ossification defect, and finally, osteoblast development defect with collagen insufficiency. And you can see on the right-hand side the types of genetic mutation according to each category. What about genetic testing? As mentioned by Mary Eve, we do not need to do genetic testing in each case because, yes, OI is a clinical diagnosis. And to be honest, in every case, whatever the genetic type, we're going to prescribe bisphosphonates. But to be honest, sometimes it's nice to know the genetic type of OI, especially when the manifestations are not straightforward. In such a case, availability is a challenge in resource-limited countries and the cost as well. So I think you agree that OI is a model of various spectrum and severity of the same disease. And this is what we see. We see various spectrums, various age groups, and various forms of severity. And let me tell you that the pathology in Africa and Middle East is different compared to Europe. Yes, we have mutations, but sometimes the pathology is different, the role of consanguinity, the area where we live, yes, the pathology is different. And I think this deserves a comparison or digging deeper to look for novel mutations in this very unique area of the world. And don't forget to look for the uncommon. I showed you some relatively common types of OI, but sometimes the story is not straightforward. This is Mohammed, an 8-year-old boy, which was really puzzling to me. He came with recurrent fractures, bowing, he was short, the sclera is normal, it's not blue, hearing and teeth are normal, severe osteopenia and thinning of the ribs, as you see. But this was the characteristic feature, mineralization of the interosseous membrane between the radius and the ulna, as you see, and metaphyseal radiodense bands in the long bone, very clear in such a case, and hypertrophic callus of the femur after fracture, which is not the usual callus that we see. It was extremely large and hypertrophic. Again, the DEXA scan scores were very low. So this is type 5 OI, and to be honest, we needed to be a little bit sure. Adding to these criteria, we were lucky to do genetic testing. And we found homozygote mutation of IFITM5. So this is type 5 OI. It's not a classical type, and it's not a very common type of OI. And this is when I asked Mohammed to draw how he felt. He drew himself very sad, as if he is in prison and he couldn't play outside or enjoy his time in the sun. Again, heavy psychological burden. Imagine an 8-year-old kid drawing himself this way. And this is another story. This is Khadija. Khadija is a 10-year-old Libyan girl who moved to Cairo recently. And what was unique about this case is that the girl had OI with a high alkaline phosphatase. And all know her parents are first cousin. And again, in Libya, consanguinity is very common, like Cairo and maybe more. She had recurrent fractures since the age of 2 years. She's short. She has limb deformities and bone pain, vertebral compression fractures, and she became on a wheelchair 3 years ago. At the beginning, she looked like type 4 OI, but more severe. But what was unique, as I told you, is that the alkaline phosphatase was high. And she didn't improve a lot on pamidronate. She took pamidronate in Libya, and she didn't improve a lot. This is type 6 OI. And we found a SERPINF1 gene mutation in this girl. And it's a very rare type of OI, 8 reports worldwide. And this is the 9th. Maybe the list grew more, but this is to the best of my knowledge. And this is Sarah, OI type 8. Parents are first cousin. She had severe fractures at birth, osteopenia, severely short. You can see she has a round face with barrel-shaped chest, and the sclera is white. It's not blue. The skull is extremely soft with widely open fontanelle, and you can see gracile undermineralized ribs and long bones with bulging metaphysis, as you see. And this is a fracture here, and this is extremely osteopenic and compressed vertebrae, multiple compression fractures. To be honest, at the beginning, she looked like OI type 3, but the sclera was white. So the genetics showed the final answer, LEPR gene mutation. So sometimes genetics gives you the final answer, but as we said, it's not available all the time. Another challenge, which I think everywhere, but even more in low-income country, is the OI multidisciplinary team. It's not only the pediatric endocrinologist. We need an orthopedic surgeon, metabolic bone disease, psychological support, cardiologist, pulmonologist, audiologist, sometimes neurosurgeon, dentist, dietitian, physiotherapist, and even more. We need a lot of people putting their hand in hand to help those children. We need the team in the diagnosis and in the management. We need a lot of human resources and facilities, as we said, tertiary care centers. And we need money for all this. So it's a really intermingled cycle of challenge to offer multidisciplinary care team. Of course, the imaging modalities for assessing bone health are a lot. The gold standard, as we know, is the DEXA-Z score. But to be honest, it's not always easy to find DEXA apparatus, especially in children less than the age of 3 years. And this is the DEXA, of course, it's the assessment tool, the gold standard for assessing the bone mineral density. And these are the parameters that we see. It's precise, easy, low level of radiation, quite accurate, but there is current lack of standardized normative data. And we are working on establishing DEXA-Z scores in Egyptian children and adolescents. And of course, in children like OI who are short, there is growth-related problems, so we need to adjust the Z score based on the height. And this is how the DEXA-Z score looks like. You can see here, this is the Z score where we look at, and the T score is for young adults. So we focus on the Z score, and as you all know, below -2 is considered low. Vertebral fracture assessment, better by plain X-ray spine rather than the DEXA scan. So you can see the osteopenia and the fractures of vertebral column better by the plain X-ray. And it's better to do a plain X-ray if there is severe or persistent back pain, generally speaking, not just in OI. Another challenge in resource-limited settings is having a well-integrated management plan. We need to set a plan because OI is a lifelong disease. It's not a common cold that will resolve. You need to keep an eye on your patient and to set an integrated plan. And this is how you take it in OI children. First of all, when you suspect and when you start the bisphosphonate, you do the DEXA scan before and you follow up on yearly basis with the DEXA scan. You do at first the calcium profile, calcium, phosphorus, alkaline phosphatase, parathyroid hormone. You diagnose, and then you start treatment. So it's a multidisciplinary, comprehensive approach. And let me tell you that the choice of bisphosphonate in my country is based on availability, because the challenge here is not which of them is more effective, it's which of them is available. 10 years ago, we used to have pamidronate in Egypt. Nowadays, we have the zoledronic acid. So we use the zoledronic acid. Thanks God it's available now. It is quite effective and available. But in my country, the challenge is availability. So we choose based on which type is available. And this is to show you the radiodense lines seen in the long bones correlating with growth arrest and subsequent recovery in patients treated with bisphosphonate. And my lovely patients allowed me, I took permission to share these photos. These are our zoledronic acid days. Patients come with their families because the cost is high for the patients. So what we do is that we open the zoledronic acid ampoules and we divide them between the patients instead of each one paying separately. And I can tell you that it's not just a medical treatment, it's a strong psychological treatment for the patients and their families. They turn out to be friends, they meet each other, they share experiences, they share the phone numbers, they feel that the disease is there. It's not just my kid or my child. So it has a very strong positive psychological impact for them, and it helps them to grow out of their disease. Again, memories, patients with Zumita days or zoledronic acid days, they see each other improving and they share hope with each other. Another challenge is implementing research in resource-limited setting. Let me tell you, it's not as easy as in Europe or US. It's really a challenge sometimes to raise funds and to implement research. The good thing is that we are a huge population, so we have a lot of everything, even the rare condition. Relatively, we have good numbers of patients, but we need fund and support. This is a research that we conducted at Ain Shams University, my university, where we included 84 patients with OI. We subjected them to full anthropometry, and we compared nutrition and anthropometry in patients before and after zoledronic acid. We published it in Hormone Research in Pediatrics. And this was our conclusion, the baseline data and 2 years after zoledronic acid. Zoledronic acid improved growth velocity, especially in the milder types of OI, when zoledronic acid did not have an effect on nutritional parameters. The weight was not affected, but all the height parameters improved after zoledronic acid. And this is another study that I would like to share with you. It's unpublished data. We did not publish it yet. We found improved height SDS after 1 year of growth hormone therapy in 87 Egyptian OI children. In the previous research, we did not give growth hormone. We just gave zoledronic acid and we assessed the growth. Here we gave growth hormone, mainly in the classical types of OI, type 1, 3, and 4, and we assessed the height Z score. Of course, growth hormone therapy is not approved in OI children, but sometimes parents and the child are very much annoyed with the short stature problem, and they request growth hormone. We found improved height SDS after 1 year of growth hormone therapy among our 87 Egyptian OI children, and we found the response better in the milder types. The best response in the height was in type 1, followed by type 4, and then type 3 and the other types. So again, it is related to severity of OI, which confirms that the short stature is part of the metabolic bone process rather than a pure endocrinal problem. We also did another research, still unpublished data, extraskeletal manifestations in Egyptian children with OI. We recruited 96 OI cases. We classified them into col mutations and non-col mutations based on genetic testing, and we screened for extraskeletal manifestations in those children. The most frequent association was short stature and followed by respiratory complications. There were also other problems that you can see, but less frequent, like hearing affection, cardiac, renal, developmental, and blue sclera. Another challenge, which I think is found everywhere, but maybe more in my country and in resource-limited patients' countries, is the transition of OI cases from pediatric to adult care. It's a big, big challenge. It's really difficult, I think, in all endocrine problems, but speaking of OI, it's even more challenging because OI cases, as we mentioned, need multidisciplinary approach. They need education. They need readiness, whether physical or psychological. They need preparation. They need to move smoothly from the pediatrician to the adult pediatric endocrinologist. So it's really a process that needs good preparation for patient and the family, for them to accept the change. Another important challenge that we are trying to work upon, and I think the GPED is doing the same, is raising awareness about OI. And the Wishbone Day was a very good chance to do this. And conducting 2 webinars by GPED in collaboration with ASPED was a very good opportunity to raise awareness among doctors, among patients, among the community. This is really, really important. I showed you examples of cases that were misdiagnosed by pediatrician and even orthopedic surgeon. So yes, we need to raise our voice and shout louder that there is a disease called OI and there are milder forms and there is a diversity in such cases. We need to educate patients, families, doctors, and I think the whole community. And this is a challenge as well. So just to sum up what I've said throughout my presentation, this is the long list of OI challenges that we see in our resource-limited settings in the area where I live. Late diagnosis, heavy psychological burden on patients and families, referral to tertiary care centers, genetic testing, although not needed in every case, availability and cost, the multidisciplinary team having and formulating a well-integrated management plan, the medications availability and cost, transition from pediatric to adult care, and raising awareness about OI. And I'm sure there are other challenges that maybe I missed or I didn't mention, but all the challenges and the cases that I showed you are real life scenarios that we live with, real life stories and challenges that we feel every day when dealing with those patients. And I think that different cases of OI share the same story and they have the same challenges. And the main challenge is improving the quality of life, which is by itself is a very big challenge in every OI case, but maybe more in resource limited settings in the area where I live. Finally, I'd like to thank our Osteogenesis Imperfecta team at Ain Shams University. The names and the occupations are listed because every single person puts on hand in order to save the lives and to help those lovely children who deserve a good quality of life. And finally, I took permission of sharing those photos. They are trying to express that they could be happy, they deserve a good quality of life, and I think we all should work hand in hand to offer them the best quality of life and to share their lives properly like other children. Thank you very much for your attention.
Yeah, Thank you very much, Professor Hamza, for the insightful and inspiring presentation. Your talk has given us a deeper understanding of the many challenges faced by children and families living with osteogenesis imperfecta, particularly in the low and middle income countries. Now we will now proceed the discussion session. So I think we have a lot of patience today, and we will see the first question from audience. So this is the first question from Sahid Aziz from Pakistan. How to differentiate metaphyseal dysplasia from rickets on physical examination and radiology? Maybe, yeah, Dr. Maria If.
Yes, I can take this one. I actually have a slide on that, so I think it would be, can I share? Okay, yes, great, because I just want to show, just because it's easier to see X-ray. So I didn't touch on that, but it's very possible with both the history and the physical exam to differentiate the two. So when you think about physical exam, the main thing is that when you have a child with rickets, typically they will have proportionate short stature. The child with metaphyseal dysplasia, they'll have short limb and a normal trunk, okay? When you examine the child with metaphyseal dysplasia, they will have normal wrist. They will not be enlarged. Rickets, they'll have enlarged wrist and they'll have the rachitic rosary. In rickets, they'll be hypotonic. Usually they will be weak. Metaphyseal dysplasia are normal. And then the pain is different. In rickets, they're just kind of an overall pain. They're kind of miserable everywhere. The metaphyseal dysplasia will be very localized pain, very mechanical to the joints. And their teeth will be normal. That's very important. In rickets, most of the time you'll have enamel hypoplasia, so you'll have kind of this brown patches on the teeth, and you may have delayed dentition and caries. And then the course obviously is also important because it's depending on how it does with treatment. And if you're not sure, you can always treat like rickets and see how they do. Within 3 months, a nutritional rickets should be improved, which is not going to be the same for metaphyseal dysplasia. And on X-ray, that's how it looks different. So on the right side is rickets, and the left is metaphyseal dysplasia. So the rickets usually is really like you have this fraying, which looks different on metaphyseal dysplasia. It's not really frayed. And the growth plate widening is really just present with rickets. So kind of this difference of the growth plate is going to be larger here, the space, which is not the case in metaphyseal dysplasia. And then the cupping also is not present in metaphyseal dysplasia. This is not cupped. So usually you don't need your labs to be able to differentiate both. Yeah, that's the slide I had.
Okay, so thank you very much. And the next question. Okay, so this is from Sabin Khan and Mumtaz Hussein. Treatment can be started in neonates, and can we start biphosphonate before 6 months of age? And is it safe? So I will give to Dr. Maria F and also Dr. Rasha also. Yeah, you can give a comment, both of you.
Yes, definitely right. So we want to start with that.
Yeah. Dr. Rasha, you want to give a comment first?
Okay, I'll go for this. Yes, I haven't given it to neonates, or maybe let's say the youngest age that I have given bisphosphonate was 1 month. I'm not sure. I think Mary Eve said in her presentation that as early as 3 to 5 days. Yeah, am I correct?
Yes.
So,
yes.
The youngest age that I used bisphosphonate was 1 month for me. And of course, you have to be very careful. You have to start with very small dose, water the usual dose, and monitor very well and give it very slowly. So it's not the usual thing, but sometimes the fractures are intolerable, so we have to start early.
Yeah. And how about your experience, Maria?
Yes, I think it's really important to start early, and to use, because usually those infants will be in the neonatal intensive care unit, they'll be admitted, so you want to kind of use that time while they're monitored, while they are monitored for their respiratory status. And the reason we start early is for pain, but also to protect the spine, because the really severe ones, they will have vertebral fractures. It's a matter of time, so you want to intervene before they start having vertebral fractures.
Yeah. So in your experience, for the little type of OI, do we need also to give like very like even they are not, their condition is not so good, can we give a biphosphonate or not?
I do, yes, absolutely. So regardless of the type, I just make sure the renal function's established, because the first few days, the renal function's not yet established, but usually 3 to 5 days it is. And most of the time, the lethal forms, they're intubated anyways. So I'm not worried about the respiratory compromise that can sometimes happen when you give bisphosphonates. So I give them bisphosphonates early, yes, for the pain mainly.
Okay, so thank you so much. And the next question. Okay, so this is the question from Sheikh Saddam Hussein. How to differentiate between mild OI and idiopathic juvenile osteoporosis if we have a child presenting at age of 7 years for the first time in life? Who will give a comment first? Maria-Eve? Yeah.
Sure. I see, like, I know we talked about OI today, but I really see all of those diseases as a spectrum. So you have a genetic form of bone fragility. It can be caused by a lot of mutations. And sometimes people call them IGO. That just means to me that no one found a gene. That's why we're saying it's idiopathic, but it's probably a gene that we just haven't found. So it's not really important, in my opinion, to differentiate if it's idiopathic juvenile osteoporosis or OI. You have a genetic cause of bone fragility. Doesn't matter what the gene is, you would treat anyways. And sometimes we know, like in the IGO, like if you do sequence those children, the vast majority will still have COL1A1, COL1A2 mutation. And they'll just look like IGO because they don't have a blue sclera, they don't have Osteogenesis Imperfecta. So the textbook answer will be you need genetic testing to make the difference, but my answer would be I call them genetic bone disorder, causing bone fragility, and then I treat them.
Okay. How about your opinion, Rasha, compared with the limited resources if you don't have like genetic testing?
Let me tell you, this is the usual in most of the cases, not to have genetic testing. In such a case, as Marie-Eve said, my aim is to stop the fractures. So in both cases, if there is osteoporosis and I don't know the cause, I will go for treating, and I need the patient to stop having fracture. But the only way to say, yes, I'm sure of the diagnosis is to do the genetic testing, of course. But yes, I would treat, and this is the priority, not the priority to know, is it this or that? Although I think maybe radiologically, even in the milder types of OI, it will not look the same like idiopathic juvenile osteoporosis, maybe, but I couldn't rely on this. It's the genetic testing.
Okay, so thank you very much. And we will go to the next question. Okay, what is the role of growth hormone in OI? I think it will go to Dr. Rasha because you have already the study about this. What is your comment?
As I previously mentioned, it is not FDA approved indication for OI, of course, and OI patients are not growth hormone deficient, of course, it's a metabolic bone disease. So giving growth hormone is something extra. For me, what I do not give it to every short patient with OI. It's if they have severe short stature. And to be honest, when the parents request me to prescribe growth hormone to improve the height, as I showed you in the study, the milder the type, the better the growth response on growth hormone therapy. And but I couldn't say that I give it to every case, probably because of the cost. It's not easy to pay this money in every case, especially that they are not insured. The Egyptian health insurance does not offer growth hormone for OI cases, so they have to buy it on their own expense. But in the study, we found improvement in the growth velocity, but of course, with the zoledronic acid reducing the fractures first. So it's first the zoledronic acid and then the growth hormone. We couldn't just give growth hormone and the child is experiencing a lot of fractures.
And in your study, do you find like increasing of scoliosis or not in the patient?
In milder cases, when the scoliosis is less than 12, we gave growth hormone. This is what we did in the study. But those with larger degrees of scoliosis, more than 12 degrees, we did not give growth hormone. We did not find a significant difference. The scoliosis did not increase a lot, but this could be because the patients from the beginning did not have severe scoliosis. So it was an exclusion criteria. If the degree of scoliosis more than 12 degrees, we did not give them growth hormone.
Okay, so thank you so much. And the next question, please. Okay, so in OI, after orthopedic surgery like osteomy, when can resume zoledronic acid? After callus formation? Okay, so Dr. Maria, if do you have any comment on this question?
So when we look at a lot of patients that had the osteotomy, it looks like 4 months is the magic number. So you want to wait 4 months or until the bone is mostly healed, so until there's callus. But it's pretty rare at 4 months that the callus is not formed. So that's a pretty safe number to give.
Okay. Okay, thank you. I think we still have maybe around 4 minutes. So next question. We have so many questions today. Okay. So is biphosphonate given every 6 months ever in severe OI or can be given 4 months in patient above 2 years of age? You wanted to give a comment, Dr. Maria?
Yes, we're probably talking about this about zoledronate here because it depends on which agent you use. But for zoledronate, yes, it's every 6 months when you're over 2 years of age. And having the severity of OI does not influence the frequency of zoledronate because it'll stay so long. So you don't have to give it more frequently, even in severe OI. You can still give it every 6 months.
Okay, so even the OI is very severe, we do not need to to give 4 months, every 4 months, yeah.
Unless they have pain, that's my experience, or unless they have another. Oh, go ahead, Dr. Hamza, you want to say something?
Yeah. And Dr. Rasha?
Yeah, what we do at our university is that if the fracture rate is high while the patient is on bisphosphonate every 6 months, sometimes we give half the dose, 0.025, every 3 months. And they improve a bit. So it improves the pain and the rate of fractures gets less. But this is not the classic. We do this in patients who are not responding well on every 6 months. This is what we do.
Okay, because I also have several patients that have very severe OI and many fractures every month. So maybe we can do it, yeah, to lower the dose, but we every 3 months. Yeah. Okay, thank you so much for your insight. And maybe we still have one question for the last question, I think. So, best time for biphosphonate while patient have recent fracture, when to be given, if surgery treated or conservative, any guidance? Okay, maybe it's the best time for a biphosphonate treatment for the recent fracture. Is any comment, Dr. Maria If?
Yeah, so very important to never delay bisphosphonates for fractures. So you just want to give it. If there is surgery that's going to be planned, you want to make sure you have at least 24 hours between the time of bisphosphonates and the time of surgery, because bisphosphonates only stays in the blood for 24 hours. So as long as you have that, you don't have to delay your surgery or delay delay your surgery. So very important, because kids with OI fracture all the time. So if you start holding your dose for fractures, you're gonna not have a lot of therapy.
Okay. Dr. Rasha, do you have any comment on this also?
Thank you. Totally agree. Yeah, I totally agree.
Yeah. Okay, thank you very much. And because of the time, I think this is the last question from the audience. And this marked the end of the discussion session. And on behalf of GPED, I would like to extend my deepest gratitude to Dr. Maria Eve and Prof. Rasha Hamza for their time and for being willing to share their expertise with us today. Through this webinar, we have learned more about the challenges faced by individuals with OI, from early diagnosis and multidisciplinary management to long-term support and quality of life. We hope today's session encouraged greater awareness, collaboration, and continued effort to improve care for patients and families living with OI. Thank you again for your participation, and we look forward to meeting you in our future educational event. Have a wonderful day, and I will now hand over the session back to Arnita as our MC.
Thank you very much, Dr. Agustini, as well as to Dr. Mary F. and Dr. Rasha. We will now have a photo session with all our speakers. So to the participants, if you can turn your videos on, that would be greatly appreciated. I will now be taking the picture. 1, 2, 3. 1, 2, 3. I will wait for a couple more seconds. Okay, 3, 2, 1. 3, 2, 1. Thank you very much.
Okay.
So, once again, on behalf of the organizing committee, we would like to extend our warmest round of gratitude and appreciation to all our speakers and moderator for the incredible lessons and insights that we have learned today. To all the participants, please fill in the feedback form as detailed on the slides and sent via the Zoom and YouTube chat. The certificate of attendance will be shared via email upon completion of the feedback form. GPED also conducts routine webinars as well as other very exciting activities and opportunities for you. We will also have a webinar on World Thyroid Day on Sunday, 24 May 2026. So please register via the link on the slide. And on the 21st to the 22nd and 28 to 29 November 2026, we will also be hosting the third GPED annual meeting with a very exciting team, doing more with less, managing pediatric endocrinology and diabetes in challenging settings. Registrations and abstract submissions will open this month, so please stay tuned. To keep yourself up to date, we also urge you to follow GPED on our social media platforms as detailed on this slide. And please register to become a member of GPED via the website as seen on the slide as well. Once again, warmest round of gratitude to all the parties who have made this webinar a great success. Thank you, and we hope to see you at the next webinar.